Nice to see everyone.
Yeah, good day, everyone. It's fabulous to have you here. I'm your host, Dr. Allison Fiducia. If you're new to the Psychedelic Support Speaker Series, we do this once a month and invite different speakers to discuss the latest topics in psychedelics, research, policy, law, health, and other topics that are of interest to this community. Today, we will be discussing psychedelics for chronic pain. And as you're aware, most of the research has been conducted on mental health benefits of psychedelic substances, but we also see promise in the initial research trials and from anecdotal evidence that psychedelics may help with physical conditions like neuropathic pain, headache, spinal cord injury, traumatic brain injury, fibromyalgia, long COVID, and more. So it's great to have this conversation today. And as always, you're welcome to say hello in the chat where you're calling in from. And for our speaker today is Court Wing. And it's great to have this varied perspective of Court. He in 2020 participated in NYU's clinical trial for psilocybin for major depressive disorder. And by the end of the psilocybin sessions, he not only felt his depression symptoms lift, but noticed that he was no longer suffering from a chronic pain condition that he had from some previous injuries. From his professional experience, he sought to learn more and to help others with chronic pain because he has worked for many years with clients to meet their athletic performance goals. And as part of that, as we know with athletes, injuries are common, and with that comes pain. So Court is the founder and CEO of Remap Therapeutics and the co-founder of the Psychedelics and Pain Association, which we'll be hearing more about today. And I'll drop the links into the chat so you can find out more about Court, Remap, and the Pain Association. So it's great to have you here, Court.
Thanks so much for having me, Allie. Really looking forward to this. And, there's a soft spot in my heart for psychedelic.support because when I first came out of the clinical trials back in March of 2020, yours was one of the only organizations that was out there. You folks like Psychedelics Today who've also been, working with me, but you guys, as soon as you had your certification available or your coursework available, I should say, I took it as fast as I could. So,
well, thanks for that. Yes, we have lots of different offerings, free courses, as well as more advanced training and courses people can take. And as there's more to learn about pain, perhaps we could make a course together.
That would be wonderful.
Yeah.
Absolutely.
All right.
Okay, so let me just go into screen share here. I'm Court Wing, and there's a presentation on major depressive disorder and persistent chronic pain featuring case studies with phantom limb pain, long COVID, CRPS, and the key mechanisms of action. As Allie mentioned, I'm the founder and CEO of Remap Therapeutics, as well as the co-founder of the Psychedelics and Pain Association in collaboration with Psychedelics Today and Cluster Busters. And I have a 30-year background as a pain and performance specialist. Part of that is that I was the co-founder of the very first CrossFit in all of New York, as well as the principal programmer for the UN's Close Diplomatic Security physical assessment and preparation course. I've had a very varied career working with thousands of students, hundreds of clients. And in March of 2020, I was a study participant in the NYU USONA clinical trial of psilocybin for major depressive disorder. By the end of my dosing day, I was in complete and total remission from a 5-year episode of increasingly treatment-resistant depression. Far more shockingly, I was also in full remission from ongoing low to moderate chronic pain. And as a direct result, I immediately dove into investigating what had happened to me, and that's how both Remap Therapeutics and the Psychedelics and Pain Association was born. So we followed standard trial dosing and protocol, 25 milligrams per 70 kilograms of body weight, and that is the actual cup I chose to receive mine in. We did it with 2 facilitators, an eye mask, and a curated playlist. And this is the actual session room and setup for my dosing on March 5th of 2020 at NYU. So from my background in applied neurophysiology, I had a deep familiarity with inducing neuroplasticity with visual, vestibular, and proprioceptive inputs to improve pain and performance via sensory motor output. So I was able to track the mechanisms and pathways of the resolution of my physical pain in real time. And my first ray of hope was 3 weeks before my dosing. This review paper discussed how the mechanisms behind psychedelics treating depression were more than just psychological reframing, as powerful as that can be. So dendritic arborization and complexity, synaptogenesis, spinal trunk density and thickness, and neurodegenesis. And it demonstrated that structural neuroplasticity was operating across multiple compounds. And in the depths of my depression, I had completely lost track of how it causes atrophy and dysfunction in the prefrontal cortex. And desperately trying not to hope, I began to wonder if I might get some relief. And how did I know I was in full remission? At the end of my session, I didn't just feel better. It was shockingly, glaringly gone. It's a qualitatively different remission from other antidepressants. It's one thing to read about 30% remission rates by end of day. It is radically different to experience it for yourself. And you can see me in the trial data. I'm right here above on the right. If you look at the left side of the right chart, the orange line's going down from 40 to 0, right? So my baseline MADRS was at 40 plus, and it dropped all the way down to 0. And this was confirmed by both my primary investigator and USONA. Day 8 looks like the first day of baseline 0, but that's misleading because all the assessment questions started with in the previous 7 days. So I couldn't count the ongoing remission in the first week. But far more shockingly, all my pain was completely gone. I had assumed it was a life sentence after decades of intense training. And I recovered my mobility the morning after dosing with restored range of motion, strength, and motor control. And I had started having neurological revisioning right there on the session couch with intensive tremoring in my leg. But due to my training background, I was familiar with approaches using shaking and fasciculations for sensory motor recalibration. So I didn't have a sense of threat around it. It actually felt incredibly good, like a TENS unit. And laying there the morning after, all at once it came to me with visual field interaction this rich and neuroplasticity driving a remission this strongly and rapidly, why couldn't you combine high-dose psilocybin with Mirrorbox therapy to treat phantom limb pain? More than a decade earlier, I had worked with a young vet returning from Iraq who had severe complex regional pain syndrome, CRPS, on what appeared to be a whole, fully functioning leg, but it was on fire 24/7. And finally, in a desperate attempt to escape the pain, he had his leg surgically removed. I had blogged about Mirrorbox therapy after learning of it through my certifications in approximately 2015. Simultaneously, that's when I first also learned of the work of cluster busters using psychedelics to treat cluster headaches. When I went into, so when we look at, modern survey studies now, so this is some unpublished work here out of Clusterbusters, right? Very similar to the early work they did. We see that people respond strongly towards the left side of this graph with psilocybin, LSD, and DMT. Those are the ones where we're seeing the largest promise because there's the highest degree of responsiveness. And when we look at the work of Emanuel Schindler today out of Yale, it closely mirrors the work that she was doing previously. So in this case, what we see is that studying cluster headache patients in an active cluster cycle, this is a 3-dose pulse regimen using low-dose psilocybin. And what it shows is about a 50% reduction in the number of attacks per week. And it's worth noting, you know, people with cluster headache, and this has been the case going all the way back, as was rapidly discovered, they take a low dose of about 1 to 1.5 grams of dried psilocybin mushroom once every 5 days, and 3 doses seem to work for most, but others may find a difference in how they respond to that schedule and dosing. So when I went into my first post-dosing assessment, I practically yelled at my researchers that this was going to change how chronic pain was treated within the next 5 years. And 10 days later, New York City was shut down for the COVID quarantine. And I just cannot imagine what 2020 would have been like if I had received the placebo. So I dove into the research, and within 3 weeks, I found the Kuromaro study from 1962, low-dose LSD for phantom limb pain. It was a pilot study that began in Japan in 1958, 1 year after Sputnik and the Life magazine article on magic mushrooms. And it was reprinted in the Lancet in 1967. They used only 50 micrograms in order to remain cognitively available and postulated that phantom limb pain was due to dysfunctional body schemata, with evidence that movement and motor afferents caused revisions in phantom limb sensation during dosing, causing them to resect into the residual limb. And they showed that there was increased EMG output in that residual limb. So 7 out of 8 had reductions or loss of phantom limb pain, but no one was citing it. Everybody was citing CAST as the first study on psychedelics and pain. So the LSD cancer study by Cast and Collins was published in 1964. We have 50 patients with terminal cancer, dry gangrene, and severe shingles. Taking 100 micrograms left 50% in total analgesic relief from 19 plus hours up to 3 weeks. And the average for total relief periods was 16 times higher than standard opioids. Many of them had significant reductions or elimination of existential anxiety and depression and anhedonia. This took place at the open cancer ward at Cook County Hospital, traditionally the hospital for indigent alcoholics. There was no preparation, facilitation, or integration, and there was no informed consent. Despite these limitations, they still produced these results. So my remission continued to expand outside of my restored range of motion, strength, and mobility. My cold water tolerance significantly increased. I had a 30-plus year background as a cold water practitioner from my key Aikido career. But during my depression, cold showers had become strikingly painful. It was just incredibly demoralizing. But now, post-dosing, I could stand under for minutes at a time with absolutely no discomfort. It felt like it was happening to someone else. And I was familiar with the cold pressor test that was used for pain measurement in studies. And then that same year, Professor Rawmakers at Maastricht released a study showing Low dose LSD, 20 micrograms, decreased pain perception and intensity, and increased cold water tolerance. So then the biggest surprise of all happened. 2 months after my dosing, Dr. Joel Castellanos and the entire team from PHRI at UC San Diego released their landmark review study, Chronic Pain and Psychedelics, a review and proposed mechanism of action. Astonishingly, buried within was the case study of Albert Lynn and V.S. Ramachandran, the renowned neuroscientists who had discovered Mirrorbox therapy. It was published in 2018. And of course, I wasn't the first. Lynn had chosen elective surgical amputation after a difficult recovery from a severe car accident, resulting in immediate intractable phantom limb pain. And Mirrorbox therapy provided acute relief, but it wasn't enduring. And then Lynn became aware of cluster headaches and psilocybin treatment from his GP, Dr. Timothy Furnish, likely from research published by Schindler et al. In 2015. So he began to use psilocybin, and it also provided temporary relief, but with a pain slapback and intensification after. So his wife suggested, why didn't he try combining the two together? In the modern investigation of psychedelics and chronic pain, this is ground zero outside of the cluster headache community's work. He had total analgesia for nearly 24 hours, then a 50% reduction in his pain baseline for 2+ weeks. So he shared the results with the Ramachandran lab, and they began experimenting with different types of neurovisual modulation with high-dose psilocybin. His baseline pain continued to decrease until total remission at 5 weeks. And just note the difference here between dosing for cluster headaches and phantom limb pain and other conditions of central sensitization. Cluster headaches top out significantly lower. So combining psilocybin with adjunctive neuromodulation makes them far more impactful and enduring. So when we investigate psychedelics and profound analgesic relief, what are the key mechanisms of action? So 5-HT2A is the primary serotonin receptor responsible for producing psychoactive effects from classic psychedelics, and is the only 5-HT receptor which generates persisting descending inhibition past nerve ligation. And it's likely a potential contributor for emerging signal in case reports of peripheral neuropathy, nerve denervation, and deafferentation. Analgesia produced by the 5-HT1A and 2A receptors improve with repeated treatment, it's suggested, whereas opioid receptors develop upregulation and decreased therapeutic effect. Rebus is a proposed model describing cortical reorganization from psychedelics for depression and other mood disorders. Maladaptive top-down cortical outputs, known as strong priors, suppress sensory-driven bottom-up error correction, and it fails to update the prediction model. This occurs largely within the default mode network. There's multiple types of nosoplastic output, autonomic negative thoughts, self-perception image and frameworks, all characterized as cognitive inflexibility, aka rigid thinking, within psychiatric conditions. And just note the similarities here to central sensitization regarding both nociceptive and non-nociceptive inputs and outputs. During the entropic state induced by psychedelics, it produces a flattening of the cortical landscape, allowing connections between distant processing nodes and structures, creating novel, efficient, and effective priors, facilitating improved mapping and cortical representations. So recall here, in the Kuromaro study, we see a decrease of phantom limb sensation with movement, creating that error correction within the neuroplastic window. Many psychiatric conditions are highly bidirectional with chronic pain, such as depression or PTSD. In fact, the classic description of this process is the psychological and physical vicious circles, where sensitization emerges with decreasing activity, leading to the start of kinesiophobia. And this is evidenced in the first study of MDMA and chronic pain by Christie et al. In PTSD survivors. Those having the highest pain baselines had the greatest decreases in chronic pain at study endpoint, even though it was not a stated primary outcome, so there was no expectancy bias. In my ongoing remission, I just didn't ache anymore. Like the highest density of serotonin receptors are in the GI tract, and I had altered gut sensation for a month plus. And the first place I felt the effects of psilocybin on my dosing day was in my viscera. And depression is a neuroinflammatory condition, and so much chronic pain is derived from inflammation. And I had become effortlessly responsive again to exercise and neuro rehab interventions, with significant improvements in my working memory and hand-eye coordination. Psychedelics are potently anti-inflammatory. Nichols and Flanagan demonstrate some compounds are 700 times more potent than corticosteroids while still below the threshold of psychoactivity. And they're not immunosuppressive, but they return inflammation to default healthy baselines. They could be described as homeostatic autoregulators in their activity. Natasha Mason shows they decrease TNF alpha acutely within 24 hours and persistently reduce interleukin-6 and C-reactive protein post 7 days, leading to increased resilience in this human stress response. Multiple psychedelics improve structural neuroplasticity, and as mentioned earlier, it shows improvements in synaptogenesis, dendritic arborization and complexity, spinal trunk density and thickness. And chronic pain patients, as well as those with depressions, also display neuronal atrophy. There's brain volume reductions that are seen in areas involving pain processing. So an example, the ventrolateral prefrontal cortex, dorsolateral prefrontal cortex, posterior cingulate cortex, and the amygdala. That same year, combat vets with TBI and PTSD had begun to report astonishing recovery using psychedelics. TBI and post-concussion symptom profiles overlap significantly with long COVID. Cognitive deficits, mood dysregulation, and dysautonomia. Which brings us to MaryAnn. So MaryAnn Welke Lesage is a 44-year-old Canadian IT director, a mother of two. She was infected in the winter of 22, post-vaccination, and her long COVID symptoms included post-exertional collapse and malaise, profound cognitive decline, severe COVID headaches and head pressure. She had bilateral proximal joint pain 5 out of 7 days and severe insomnia as a result. Also, new onset depression and severe anxiety. She mistook a panic attack for a cardiac event. And as a result, she went on disability and childcare became completely untenable. She discovered in her research that the headache medicine sumatriptan was chemically similar to psilocybin. Then she found a therapist who had self-treated their own TBI with psychedelics. Pardon me. So her initial small dose led to a 15 to 20% reduction in symptom relief overall, with a headache relief of 20 to 30%. Her second larger dose combined MDMA with psilocybin mushrooms, giving an 80% reduction in her symptoms. And inside the next 5 days, she was able to return to exercise, swimming for increasing duration on multiple days, where previously any exercise debilitated her for days on end. Then she read an entire novel in that weekend, where before 5 minutes of reading took hours of recovery. Her head pressure went into immediate and complete remission, and her headaches diminished by 80%. She returned to work in July. Her final dosage after a non-COVID infection in the fall led to complete symptom resolution. This was published this past spring, and she's still in remission today. There's many similarities in symptom profiles between infection-acquired chronic illnesses like long COVID and conditions of central sensitization, over-responsive nervous and immune systems with systemic dysautonomia. This leads us to Lynn. Lynn Watkins is a 56-year-old veteran. She was a U.S. Air Force JAG officer judge, and she suffered from 20+ years of full-body CRPS type 2 with brain inflammation after a botched surgery severed her lateral femoral subcutaneous nerve. She suffered subsequent mobility loss, foot neuromas, glossodynia, multiple mood disorders, and so much more. As a result, she was medically retired. In CRPS, we see trophic changes in peripheral tissues and autonomic dysregulation, yet it's closer to a homuncular schema distribution due to sympathetic windup. It is absolutely nosoplastic. The first case study of CRPS being treated with psilocybin was from this case series in Pain Journal, published in September of 2022. It also has the second case study of psilocybin with adjunctive therapy, providing enduring analgesia for 2+ weeks reoccurringly. Additionally, it documents intensive tremoring, aided a paraplegic patient recover sensory motor deficits. And it also reports macrodoses dropped all their pain baselines to 0 within 60 minutes. And there was no tolerance, withdrawal, or rebound pain when microdoses were used daily, with 80% relief and 50% duration. Psychedelics are impact boosters for neuroplasticity and likely work synergistically with adjunctive therapies, making their rehabilitative effects more enduring. Critical period reopenings are a state of metaplasticity, where the nervous system is very malleable and notably sensitive to inputs affecting associative learning. New skills, responses, reflexes, and/or the reacquisition, of diminished ones are possible during this period. Compounds with a longer acute experience create a longer reopening period, allowing adjunctive therapies such as neurovisual modulation, like mirror visual feedback, to become far more sticky. Lynn consumed mushrooms 3 times over 7 days. Simultaneously, she performed adjunctive neuromechanics, neurovisual modulation, and tactile reprocessing programming she had been assessed and training for the previous 8 weeks, alongside best practices in risk reduction. Her severe lateral thigh and foot neuroma pain dropped to 0 within 90 minutes, and simultaneously, she recovered motor control in her 4 smaller toes after no movement for 9 years, post-phalangeal resection, despite routine physiotherapy. Her glossidynia, burning mouth syndrome, dropped by 75%, with attack intensity no longer rising above 2 out of 10, and her fall frequency reduced by 75%. Her previous 1,200 milligram ketamine infusions every 6 to 8 weeks gave her 2 weeks of post-infusion remission, returning to a baseline of 9 out of 10. A week and a half after her final infusion, her pain was still 4 out of 10. At her 1 month post-psilocybin follow-up, her pain had decreased to 0 to 1 out of 10, as recorded in the brief pain inventory. And additionally, she recorded significant decrease in her MADRS, HAM-D, and CAP scores. Her CRPS pain remained at 0 to 1 out of 10 without ketamine for 9+ months post-dosing, with everything else in continuing remission for more than a year. It was published 3 weeks ago today. Lynn is not alone. Pardon me. There are this qualitative survey from Imperial by Bornman and Close shows pain dropping to 0 within 60 minutes for macrodoses. All patients were genuinely shocked at the quality of the pain relief. In those with the most prolonged relief, there is a noted somatic discharge characterized by shaking, tremoring, and a sudden tension release. Lynn, MaryAnn, and I are not alone. This Maastricht survey study in the British Journal of Pain, 250 respondents said that macrodoses provided superior analgesic relief compared to all other measures. Microdoses matched the efficacy of opioids and outperformed cannabis, over-the-counter medications, and NSAIDs. Select conditions had higher representation than their prevalence in the general population, suggesting increased efficacy. Arthritis, cluster headaches, migraine, CRPS, and fibromyalgia. You cannot treat chronic pain with psychedelics the same way you treat psychiatric conditions with psychedelics. It would leave people with cluster headaches essentially on a desert island, whereas most of the time they are more than able to self-treat with the supervision of a closely associated trusted caregiver, and they're doing it at far lower doses. That doesn't mean that there's not a range or a spectrum, because we have other cases like Lynn, where clearly close supervision and contact and communication with her extended care team made a huge difference in the outcome. But there is a neuroplastic window that has to be planned, prepped for, and fully utilized post-dosing, or there will be many patients like myself getting treated for a psychiatric condition and finding a lateral benefit for their comorbid chronic pain. But if they don't do any pain-specific interventions during that period, it will likely remiss. So for relapse, I'm sorry. So for some patients, the difference between a life worth living or not is access. With that, thank you, everyone, and just letting you all know we have our upcoming Psychedelics and Pain Symposium on September 28th and 29th. That'll be online. The first day is free. The second day is sliding scale. I believe Ali and the team at Psychedelic Support are going to have that information out as well. But here's a QR code as well as our web address for the symposium. I'll leave that up for half a sec. I'll come back to that. And just we have multiple references for this talk today. So here's where you can revisit those all. But thank you all so much. Deeply appreciated you coming to hear this today.
Great. Thanks so much, Court. I appreciate all the scientific references and the case reports that you shared. It's very
Thank you.
inspiring. And
Thank
I
you.
can tell by the conversations in the chat here that many people are looking for answers to chronic pain and very inspired by what you're sharing here.
Thank you.
Yeah. And
Just
yeah,
go ahead. No, just deeply appreciate it. It's been a long 4 years, you know, and as they say, psychedelic years are like dog years. So, you know, what's available today compared to only 4 years ago, it's a radically different sphere now, you know, and we've tried to close that gap both with Remap Therapeutics as well as the Psychedelics and Pain Association. You know, we have coursework there as well, you know, high level overview, going into a lot of these mechanisms of action with many of the same researchers that were mentioned today. So people can also visit us there at psychedelicsandpain.org. Anyways, I know you guys have that all somewhere.
Okay, excellent. Yeah, so after these webinars, we will send out an email to everyone who registered with a video replay along with the links that were shared. I know there's some questions, see if we can share the slides and the references there at the end would be helpful.
I'm sure you can set something up that way.
Okay. All right. Great to hear. We do have some questions here if you're down to take some of these.
Sure thing.
Okay.
Would it be easier if I stop sharing to see them? I'll do that.
Okay.
And
if anybody else has questions, please drop them into the QA box in the dashboard. That's easiest for me to find them there. We have the first question here is about dosing.
Right.
Could you maybe chat a little bit more about the various dosing paradigms that you're aware of?
There's quite a few. So it was 25 milligrams per 70 kilograms of body weight, I believe. I believe that was per 70 kilograms of body weight. And I think that's a fairly standard dose that we see in most of the depression studies. As far as I know, that was the one at USONA, though. I think it may have been similarly employed by Compass as well. I'm not 100% certain on that, but 25 milligrams per 70 kilograms of body weight.
Yep. And so that would be a sizable dose. You would definitely feel that. I would think it's a typical dose to induce a mystical experience is how that would be described. But I am familiar a little bit with the headache trials that were conducted at Yale University of Dr. Schindler. And if you were to speak a little bit more about the dosing there, I believe it was on the lower dose side.
I think it was around 10 milligrams, 10 or 11 milligrams per 70 kilograms of body weight. So, you know, and that translates to what we were seeing in some of that, those earlier slides I was showing, you know, they're taking, you know, if they're using the pulse dose regimen for cluster headaches, and they've started experimenting now also and researching that with migraine, but certainly for cluster headaches, it's about 1 to 1.5 grams of dried mushrooms, you know, I mean, like with a standard strain, like, you know, either PE or Golden Teacher.
Right. So that's what's so important about the research trials is to understand these different types of conditions and the way people experience pain and how much dosing and how many repeats of the dosing are necessary to alleviate pain.
And maybe just worth highlighting very briefly, with cluster headaches in terms of central sensitization tend to be on the lower end. So when we're looking at things like fibromyalgia, phantom limb pain, CRPS, that definitely trends towards the higher amount. So, you know, Lynn was taking at least, I think, 3.5 to, I think, up to 5. Lynn started off with a lower dose and then worked her way up to a higher dose. You know, and it's just it's a different situation depending on the pain condition and really on the individual.
Mm-hmm. Mm-hmm. Yeah. So, can you speak a little bit about, you shared quite a lot on the physiological aspects that may be underlying the pain relief. What do you think about the psychological effects?
So I appreciate that because a lot of people, you know, get the impression by the virtue of the way I give these, you know, discussions that I'm only focused on, like, you know, the neurological aspects. So I had an absolutely profound psychological experience during my dosing. And I think they are absolutely invaluable to resolving chronic pain for many, many people. Once again, interestingly, with the cluster headache community, they don't find so much of that to be the case. Whereas for myself, you know, from what I read in Albert Lynn's reports, from what we've seen in other people's reports, certainly in Lynn Watkins' journey, as well as MaryAnn's, they absolutely attribute that, you know, psychological mystical experience, or significant altered state of consciousness as having a profound effect. You know, in my case, I dealt with some significant unresolved grief, and in the process of doing that, was able to uncover some pretty serious negative frameworks I held about myself due to the loss of someone. I had a girlfriend that had committed suicide, years and years ago. And even though it was after we had stopped being together, she was a very significant person in my life at that time, and I just could never get over it. So, and having that experience within my session work at NYU made a huge difference. But I genuinely believe also I had trained very, very hard for 2 decades. I'd been the live-in apprentice for the chief instructor in the United States in Ki Aikido. I opened the very first CrossFit in New York. I taught kettlebells to, Team 6 Navy SEALs, things like that, and I trained very hard. Even though I was emphasizing mobility and recovery work, I wasn't doing such a great job myself. And so I think I had, done enough peripheral injury and then had some pretty significant traumatic events happen within a business context, that I'd gotten this depression, and I think not being able to treat any of that led to a bit of central sensitization, and it caused the peripheral injuries to really start to become entrenched, because I used to be very responsive to physiotherapy and different types of neuromodulation and interventions like that. And I'd stopped being responsive altogether. Like, even to, prior to dosing, I see this next question here. Prior to dosing, I had tried going back on standard psychotropics and had titrated up, and suddenly I was no longer responsive. So that was very discouraging.
Yeah, absolutely. The idea that someone's writing this in the chat as well, to separate mind and body, is a little bit short-sighted, in the sense that if you have chronic pain, then you're going to be not fulfilling your daily activities in the same way, impact relationships. It can lead to things like depression, or if we think too about post-traumatic stress being stored in the body in some way. All of these make me think about, pain is also, how much does it bother you and how much does it impact your life?
Well, it's the sense of agency, right? And your self-concept, your self-image, like, someone that used to be capable of things, used to be able to look forward to certain types of relief. And when we look at the affective network and things like that, this interplay between the midbrain and the prefrontal cortex, you know, and how all of these things, the valence getting encoded on these, you know, nociceptive inputs. But most people think, you know, pain still, unfortunately, most people think pain is a sensation that's received out in the body, that's traveling up the, you know, traveling up the spine to the brain and is a signal of damage, but that's just not the case. It's actually an output of the central nervous system. That's a perception. And it's always contextually dependent. It's, you know, almost always contextually dependent. And these other aspects of our life within this whole larger biopsychosocial model, you know, really can make an impact on how we have that pain neurotag, that neurosignature. Not to say there's not actual damage, not to say that there aren't severe, significant neurodegenerative conditions or anything like that, but these other aspects play a huge factor in there.
Yeah, absolutely. Thanks for sharing that. This next question is asking about antidepressants and microdosing or large dose mushrooms. I did just post a link here in the chat from a webinar with a spirit pharmacist.
Yeah, he's great.
Yeah, well, there might not be specific health risk associated with that. It's possible that you're going to have a blunting of effect with SSRIs and psilocybin.
So, you know, our primary, that was something that I had in mind going into the study trial. Once I found out that it was even a possibility to get in, I had been taking antidepressants at that point for around roughly 3 months, and I realized, you know, I have a choice now. Like, and I'd started reading the literature and seeing that there were people that were, you know, not as responsive, that had been doing, you know, SSRIs and similar compounds into their trial. And so, you know, I very deliberately tapered off at that point, going like, I'm not feeling a difference on this. And I had felt a difference before and it wasn't going on. So I was very kind of conscious about that. And I think in my case, personally, it made a difference. But say working with Lynn, right, with her CRPS, you know, most of the people that will be coming into psychedelics with chronic pain, they will be comorbid. They will have multiple complex conditions, and usually they're polypharma. And for some of them, the you know, the payoff, the risk to the reward isn't really worth it. And so, like, you know, our principal psychiatric clinician, CJ Spotswood, who wrote the book, you know, the Microdosing Guidebook, the second half of which is dedicated to, you know, handing to your clinician if you're considering microdosing. It's like, here are all the studies backing up why this is effective. So he's a psychiatric nurse practitioner, so he is licensed to look at someone's medical regimen, and he looked at hers very closely, and we made adjustments in her schedule, titrating where we could, changing the schedule in other places. You know, some compounds have a half-life long enough that you cannot take it for a week and it won't have a negative impact. So we really try to also actively work with people's care team because, you know, we want to be informed and we want them to be informed what our approach is going to be. And we think that's what it's going to look like going forward.
Great. Yeah, that is very important. That touches on a few questions here that you could elaborate on about people asking, how do you get started with this? How do you find a therapy provider? What is this going to look like in 4 years?
Right. So I'll once again, I direct people to go to the Psychedelics and Pain Association website. We have free coursework there, right? Going over risk reduction and benefit maximization, as well as the history of investigation here, what the suspected mechanisms of action are, you know, once again, with many of these same researchers that I discussed briefly today. So people like, you know, Joel Castellanos or Emmanuel Schindler, or Natasha Mason, or Devin Christie or Dr. Joel Castellanos, Jan Raumakers, all those people, James Close and Julia Bornman, who are doing the study right now on fibromyalgia at Imperial. So all of them have been, quietly beavering away on this. And so, in our coursework, that's available at psychedelicsinpain.org. We also have what we believe to be the world's largest open database of research into psychedelics in pain conditions, neurodegenerative conditions, and inflammatory conditions. And that's starting to include infection-acquired chronic illnesses, right? So that's there. There's the original coursework that Remap Therapeutics put out 3 years ago, which was integrating neuromuscular rehabilitation with psychedelics. That's still available, though we will be updating that. We offer both consultations as well as group and solo retreats. So we're planning on having our next one. So Lynn was a referral and became a solo retreat participant just because her condition was complex enough that we felt like she would benefit from that. But there are other practitioners out there that are doing this work, and they're part of our Psychedelics and Pain network. One person that's been doing this for a very long time is Jessica at Eleusinia Retreats down in Mexico. So she has a setup down there. John Clark is doing work on this. He's also working, I believe, down in Mexico. Right now, Remap is focusing on doing our retreat work. So really, it's neuromodulation combined with harm reduction practices. So we don't actually provide psychedelics in the retreat, though they're, people are able to acquire those on their own. And we're doing it within legal localities where we feel we have the best above board legal coverage. So, Colorado is certainly one of those. And that's in the interest of making sure everyone involved feels that they are well covered. But there are practitioners out there. And but if people are interested in the Remap protocol, which we used with Lynn, they can certainly reach out to contact our team at Remap Therapeutics. But there are other practitioners.
Great. Yeah, so I've been dropping these links into the chat so people can follow up with some of these resources. And maybe time for just one last question about neurodegenerative disease and pain associated with that. Are you familiar with how psychedelics might interact?
So once again, it's inter-individual and inter-condition. If we're talking about neurodegenerative conditions, so perhaps it could be something like lupus, or we might see things similar to like Lyme's disease, once again, which is infection acquired, but they start to share symptom profile. We've seen good response, but it really depends on the individual and how if they could be specific about which neurodegenerative condition they're thinking of.
There's mentioned Parkinson's and Alzheimer's.
So Dr. Albert Romeu is going to be doing a presentation at the Psychedelics and Pain Symposium. He put out some very interesting work on Alzheimer's already. And it kind of gets back to your question about like, what's the value of the psychological experience? Because you would think with a neurodegenerative condition, and my mother passed away of Alzheimer's this past January. You would think that, of all the conditions that would benefit from psychedelics and structural neuroplasticity, this neuroregeneration, right? And all this BDNF being in the mix. That they would benefit, perhaps the most strongly. But it does seem that the impacts on their short-term memory prevent them from accessing the psychedelic experience itself. So they know something happened, but they can't remember it. So some of those benefits that can get conferred from that, experience-mediated event, like Dr. Gould-Lynn talks about in her work in critical period reopenings, right? Some of those benefits, and also I should be fair to Robin Carhart Harris, also, talks about the, experience-mediated effects as well. That in something like Alzheimer's, maybe not so much, but in Parkinson's, I think it's Dr. Josh Woolley at UCSF who's been starting to do some early research on that, and there seems to be some promise. It's just a question of what percentage of this cohort is responsive. Do they go into remission, or does it stall the progression of the disease, or are they getting a clinically significant relief? Are there, there's always a question of, who is this maybe not beneficial for? So it's kind of a wide open field still right now, but we are starting to see signal very broadly in multiple conditions.
Yeah, it's early days, but
Very.
I heard 20% of the population in the US suffers from chronic pain. So this seems like an area ripe for lots of more research and understanding who might be able to benefit from these treatments.
Yeah, one in five Americans suffer from chronic pain. 1 in 14 has high impact chronic pain, where it's completely debilitating their lives. So
yeah, well, thank you so much for the work that you're doing, and I encourage everybody to check out the references. Will be in links that I shared in the chat, and we'll be sending out a follow-up email with links and the video replay. So
thank you for everything. Deeply appreciate it. And anyone who wants to reach out, I will try to make myself as available as possible.
all right, and thanks to all the attendees here today. It's great to have you, and we'll see you next month. We'll have the details out for the speaker next month coming soon, so sign up for our newsletter.
Thank you.
All right, thanks everybody.